I call Margaret and Sjoerd also on the stage to answer your questions. The floor is open for discussion. Yeah, John, please. There's a microphone, please.
Okay. I would like the panel to imagine that they were advisors for a vaccine manufacturer who was trying to get into therapeutic vaccines. And in terms of targets, would you advise them initially to target cancer, SIN3, or productive infection, SIN1, in their program? I'd be very interested to hear this.
Does this thing work?
Can you switch on?
Okay. Well, I'm a profound cynic, as it probably came over, for therapeutic vaccines against high-grade disease and cancer. I mean, I think Sjoerd's data is extremely promising, but the difficulties are quite obvious. I think from all the animal work, and you know, we worked on therapeutic vaccination in animal models for a long time, you can have good therapeutic effect against infection and low-grade disease. The problems come, and I would have to say this to any manufacturer trying to think of a trial, that of course most people will eventually get rid of their infection. So this means the design of the trial is a tricky one. But I think that it's a much more doable thing to get a vaccine against the infection. And if HPV testing is going to become widespread, and you have large numbers of women who are HPV 16 positive, and you don't have anything to do for them, I would have said, you know, manufacturers of therapeutic vaccines should be down on their knees saying, thank God for HPV testing, because there is a big potential market.
I'd like to add something to that, John. From our own personal experience, we try to go further with our vaccine in persistence or in low-grade lesions, and there was no investor taking any chance of that. They only want to invest when this vaccine was developed for cancer. So from the manufacturer's point, this is their point. They want to hit on cancer and not on persistent lesions.
Well, I have similar experience as Sjoerd, but I mean, I try to persuade them that the market is much bigger. I mean, if you go for persistent infection, as Margaret pointed out, I mean, these ladies, they sit on a time bomb potentially, and I think they are more than willing to do something and also pay something. And you even could sell that as a prophylactic vaccine, as post-exposure prophylaxis. So I think there are many advantages, but companies.
Yeah, but maybe the return the company expects is lower from just preventing a infection or low-grade disease. They can charge more for a tumor that has been treated. So it, yeah.
Well, we have tried, but I wanted to extend the comments, and this will not be very popular, but I do not think that therapeutic intervention against CIN3 is actually ethical. And the reason is that we have a perfectly good surgical treatment for CIN3. And that's the reason why Sjoerd was finding difficulty in recruiting. The women have a diagnosis, they know they've got something inside that can be treated and removed. What the targets, I think, if you're going for high-grade disease, have to be AIN and VIN, where we do not have, VIN is a therapeutic nightmare. It's multifocal, if you go in with surgery or laser, you mutilate. And similarly with AIN3, even though the high grade is at the inner rectal junction, it's still a multifocal phenomenon in many patients. And I think therapeutic intervention by vaccination there is a perfectly reasonable thing to do.
Well, it has another advantage, I think, because you can get orphan drug. I mean, development could be on the orphan drug, which makes it a lot easier.
Betty, please. Microphone, just a second.
In your planned study, are you going to look at T cells? Are you going to try and figure out what the mechanism is?
Yeah, you know that he is my old friend Andreas, and of course he is on board, and we cannot do that with all patients, but with a subset we do. Logistically, it's a little bit more difficult than serum, but we will.
Well, actually, I would add that yes, we want to do that. We need to ship the blood overnight. 24 hours, it's okay, and then we can measure the T cells that are induced and maybe even the cytokines that are expressed. I would like to add that we have done this also with the RIP patients that we had vaccinated. And all these patients had no detectable T cell response, at least in our assay, before vaccination. And only when they developed a T cell response measurable in the peripheral blood, they also showed a response with prolonged therapeutic intervals. So I think the T cells are a very good measure of an effective immunity.
And maybe the mechanism.
And I think it is the mechanism, right? Maybe we can discuss this, because Lutz, you explained so nicely how the antibodies might be the mechanism, but Sjoerd, maybe you can speculate on the T cell part and that, except not just, you know, isotype switching, but
I can only talk about the T cells because we didn't study the antibodies, only the presence of them. We've looked at L1 specific T cells after vaccination in young kids, and you get a tremendous T cell response to the L1 vaccine. So they're definitely there. If you would go to patients with CIN2 or 3 or cancer, you will also detect in many of those, you will find perfectly healthy interferon gamma producing T helper cells against L1. And they do not seem to differ in any respect from what you find in a healthy or a vaccinated population. So I'm a little bit skeptical whether these are the cells that can target the cells that are infected in that sense. And also, as I recall from what I've heard all these years, L1 is not really expressed in the basal cells, but I might be wrong. Because Lutz sits so I give the microphone. But so in that sense, I do not see a difference between patients doing well and health subjects in the interferon gamma response to L1, but we do see a difference against the early antigens.
I mean, what I always suspect...
Well, there is a phenomenon known as antibody-dependent cell-mediated cytotoxicity. So, you know, just the antibody can work in various ways. I don't think... I'm with Lutz on this one. I think antibody is the mechanism in these RRP patients, and I think by preventing reinfection is probably the way. But how the antibody's doing that, it may not just be by neutralization, because you must have a field infection. I mean, Betty showed that years ago, yes. Not just in the larynx, but also in the trachea. It was latent, but it's only in the larynx that you get activation and papillomas forming, usually. So it may just not be simple neutralization. There may be other mechanisms which antibody participates in. Well, I can't see how L1 specific T cells can encounter. Tell me.
Well, I don't know, but I mean, Andreas just reminded me the other day of the C3 cells. I mean, some of us are working with that. This is a cell line which is used in a tumor model, and you can't find L1 protein there, but it's a perfect target for after L1 immunization. And if you look hard, you find the RNA. So maybe there's a little, I mean, everyone says there's no L1 in the basal cells, but there's maybe a little bit, and this is enough to make them a target for L1.
That is actually what I suspect too. The RNA is there, it's just very tightly translationally controlled. And I think this is a little bit leaky, and some few L1 molecules are expressed, are presented, and maybe targets for T cells. But what I compare this is to what Margaret showed with the Darwinistic evolution of immunoediting. Maybe we see the same even in the premalignant disease. So the premalignant disease we see is already immunoedited so that the T cells cannot really attack these cells anymore. However, when there is new infection of new keratinocytes that have not been edited yet, there could be an effect. It's wild hypothesis. I accept that. Okay.
Can I ask a question of Sjoerd? With your synthetic long peptide vaccine, in the initial trials you had several immunizations. Is that absolutely necessary? Or because the second question is, what is the adjuvant that you're now using?
So these are different questions with different answers. We have tried, based on what we saw, we have also tried 2 vaccinations. But if we carefully look at the data, we see that there is still an increase or a broadening of the response, but also an increase in the right type of T cells after 3 vaccinations. So we still do 4 vaccinations, but if someone stops after 3 vaccinations, that's fine with us. So in our new trials, it's either 3 or 4 vaccinations, which is good enough. If you talk about the adjuvants, we have done a new trial in VIN3 in which we used Aldara as an adjuvant. So on the vaccine side, this is still under analysis, so I can't say anything about that. But we also used interferon alpha. And interferon alpha, this was in another study, not with HPV, but another type of T-cell response study. And here we showed that the right type of T-cell response that we want to see in cancer patients was really increased by using interferon alpha as an adjuvant. So in our new trial, we will use interferon alpha as an adjuvant.
And that's direct immunization.
That's
systemic administration.
It's local systemic administration. It's Spectron, so it's indeed the systemic administration, but it's nearby the vaccine. Yeah.
Well, I think this is also something we should discuss. If you do a therapeutic vaccine systemically, wouldn't it be helpful to locate the cells to the site? So you put a local Aldara treatment in combination with a therapeutic vaccine.
I wondered if we could ask John Schiller to comment on local.
I mean, we basically just recently published in a mouse model, if you do systemic vaccination, you get 0 interepithelial T cells in the vaginal tract. Okay? And so our concern is recruiting the systemic T cells to the location where the infection is. And if you do intravaginal vaccination by techniques that I won't go into, then you get a very large number of interepithelial T cells. So it seems that you either have to do one of 2 things. You have to generate them locally, or you have to recruit them effectively, because they're not normally going there and then replicating in the lesions. And you know what Connie Trimble has shown is that in women who aren't going to have regression, it was, I think one of you quoted the paper, if you're not going to get regression, you get submucosal T cells, but not interepithelial T cells. So the recruitment, location, I think is really an important feature that maybe hasn't been addressed enough in therapeutic vaccines to date.
That's a good point, John. And I'd like to add to that there was this paper of Manon Vasetos in the past on imiquimod, and we did a sub-study in that, and we looked at the immune response against HPV in the same population. And the only one that had a clinical response in the end, a good clinical response, were the ones having a good T-cell response against HPV. But they really clearly showed that the Aldara recruited all the T cells, immune cells to the lesion. I think those together will give the best response. Also in our trials now, we see that some patients that do not respond to the vaccine very well, they get Aldara afterwards, and they suddenly start to respond with a complete response. So for me, it would be like really putting them together. But as said before, the investors are not even interested in going further with VIN. So there's a little problem here.
I mean, the work that we did in the dogs, which was actually a DNA vaccine delivered by a gene gun, and in all those studies we were locally immunizing, so we were targeting the oral mucosa after we'd infected the animals. And if this was all work done with what was then the Immunotherapeutics division of GSK in Stevenage in the UK, And they had a parallel set of experiments in which they were systemically immunizing by going into the dermis on the belly. And they got no therapeutic effect, whereas we got brilliant therapeutic effects using a codon-modified E2 gene. And I think that's another point that I would make if people are targeting infections. E2 is much the best antigen. You do need to codon-modify it to get high protein expression if you're using a DNA vaccine, but that is the best target to use.
Any more questions from the floor? No? So I think we're closing the session. Lunch is served upstairs on the terrace. I thank everyone attending, and I thank especially the speakers for the wonderful discussion.